Planner webinar. We're going to give people a few minutes to arrive. So before we begin, if you could please download the GIDA Pandemic Hospital Planner Advance. A link was sent out with your reminder just an hour ago, and you can also find it on the MRC GIDA website. Okay, so we have about 250 participants with us right now, so we can start the webinar. So welcome everyone to the How to Use the GIDA Hospital Pandemic Planner tool. Today's webinar will be about 1 hour long. It will begin with a brief introduction, followed by a presentation on the GIDA Pandemic Hospital Planner tool, as well as a practical demonstration in the middle. And finally, the last 20 minutes of the webinar will be devoted to a question and answer session. So these come from questions that were submitted by you in registration, as well as the questions that you can pose live. You'll see a Q&A button on your screen where you can ask a question. And without further ado, I would like to introduce you to Dr. Katarina Hauk.
Hi, everyone. It is an absolute pleasure to have you all here virtually in our seminar room. And it's great that so many people from around the world are interested in the GIDA Pandemic Hospital Planner. And I'm very proud that we can present this tool to you today, and we hope that we will have an interesting discussion about this tool that you can actually download for free from the website of GIDA. So first, let me briefly say that the Abdul Latif Jameel Institute for Disease and Emergency Analytics was founded last year. And of course, we are right away very busy with the response to COVID-19. Our mission is to respond to health emergencies by developing analytical tools to respond to the complex health needs that populations have during the pandemic. But our second mission is to strengthen health systems and to use methods of data analytics to generate the evidence that policymakers need in order to make health systems more resilient to deal with populations in crises, as we see now around the world. The third mission of GIDA is to build partnerships and to build capacity around the world in order to respond to health emergencies. So our webinar, we hope, will fall into this, strengthening our links with you around the world and starting a discussion on how we can help around the world to strengthen capacity in hospitals and health systems more generally in dealing with COVID-19. So we will now start the webinar. And if you have any questions, you can, I think some of you have posted that beforehand, but I will pass on now to the team who will explain to you the planner. But first, we will show you a brief video that we have produced about the planner. Thank you very much.
The global scientific community is working together to find a solution. Around the world, our hospitals are on the front line of the fight, but many are at breaking point. The extreme surge in demand for hospital care is one of the most challenging tasks facing national healthcare providers. Scientific research to address this must be shared with speed and transparency to inform policymakers and the public health community worldwide. And that is why at the Jameel Institute at Imperial College London, we are opening up our minds. The GIDA Pandemic Hospital Planner allows the user to explore potential shortfalls and requirements in response to the COVID-19 pandemic across three key inputs to hospital care: beds, staff, and essential supplies. The pandemic planning tool presents a snapshot of healthcare capacity, and users can enter.
Why has this happened? Well, this is due to a mix of both the large-scale public health interventions introduced to curb the spread of the virus and prudent planning by healthcare decision makers to increase this capacity. Our work today focuses on how planning capacity, with a clear focus on available policy options, can aid in ensuring capacity availability during this pandemic. So the team behind this planner sits within the broader Centre's COVID-19 response epidemiological team. And initially we were tasked with estimating capacity for hospitals in England, the aim of this data being fed back into epidemiological models. This became a quite rapidly moving target, with different measures put in place, often with varying figures attached to these measures. Furthermore, we noticed that much of the modelling literature, while producing impressive open source tools, only incorporated capacity simply as bed numbers, which is an unrealistic proxy. And while looking at predicting critical care capacity, they didn't take into account any interventions for increasing capacity. Furthermore, we saw numerous impact assessment tools available to hospitals also did not make these often at times tough ethical choices explicit to decision makers. As such, we shifted the focus of the workstream onto producing a planning tool that's easy to use and understand, that aids high-level decision makers, either at a national or trust level, to get an idea of their current care capacity and what scenarios they can put in place to expand this capacity. This is the GIDA Hospital Pandemic Planner. We take a holistic view of healthcare capacity, incorporating three key variables that enable a system to provide healthcare: beds, staff, and equipment. We further break down beds to both critical care beds and beds on general and acute wards, while staff are partitioned into nurses, junior doctors, and senior doctors, who are generally in charge of clinical decisions on a ward. Finally, given the pathology of COVID-19, we also model how changes in ventilators affect critical care capacity. So I'll just go into a bit more detail about the methodology behind our capacity planning tool. So when looking at the tool, there's four main areas we considered. Firstly, as I mentioned, looking at the baseline capacity, so both staffing and bed numbers required here. Also a further breakdown by bed type and equipment, such as ventilator availability. In planning for scenarios too, you also have to take into account the minimum safe staff to beds ratio, as increasing bed supply alone will stretch staff further and lead to reductions in the quality of care. Second area we look at are what are the demands solely from COVID patients. So looking at the number of COVID patients by bed type they occupy and whether they need a ventilator. We also have to factor in staff sickness rates from COVID, as numerous reports have highlighted this can reach quite a high level, especially about proper testing of staff. The third area we considered were the type of interventions being enacted, looking at both those that affected the managing of admissions in a hospital, such as cancelling elective operations and triaging out high-risk patients, and those interventions which manage the care supply, so increasing bed numbers via requisitioning private sector resources or building field hospitals, for example. We looked at these interventions that had been put in place across Europe, Western Europe, to get a wide sample of enacted scenarios. And finally, when building this tool, we also took into account what would be useful outputs for decision makers, settling on how scenarios affect capacity levels per 10,000 of the population, and how these scenarios change for baseline capacity in percentage terms. We also include estimations for the total resources needed given the number of patients input to allow planners to see the degree of change required. So just to look at the interventions we've modelled in more detail. Firstly, as I mentioned, we look at interventions which affect the number of admissions into care. So we look at both how cancelling elective operations alters the number of patients in both critical care and GNA beds, and how national guidelines for prioritisation of critical care affects the number of patients within critical care. For England, to calculate the effect of cancelling elective care, we looked at data from hospital episodes during the busiest period of a previous year to identify the number of patients admitted to the hospital for elective care measures, then assumed that all these patients, as a proportion, could be removed from the patient population. A similar analysis was undertaken for the NICE guidelines, initially published in the UK on the 20th of March, which define how critical care is to be accessed based on age and an assessment of patient frailty. And then we used these guidelines and we estimated these values for critical care patients on the busiest day of the previous year to estimate how many numbers could be shifted over. Then the next category we look at into are interventions which increase capacity. So these include field hospitals, such as the Nightingale here in the UK, and then the use of private hospital resources. This is smaller in the UK and will vary dependent on our country's healthcare system. We also look at bolstering staff through the return of former healthcare workers. deployment of student doctors and international doctors resident in the country. And with equipment, we also look at how procuring new ventilators affects our capacity here. Final category of interventions we look into are those which reorganise care. So how many theatres we can convert into operating beds, how many GNA beds we can convert to critical care beds, and also how many general acute staff can be upskilled to work on critical care wards. So that's an overview of the interventions we've modelled in the planner, and there is scope within the tool for users to add their own and also to combine multiple different interventions to assess their effect on capacity. And as I mentioned, we looked across Western Europe to get an idea of the type of interventions implemented to increase capacity. The countries that we looked at are mapped in this interactive map, which is available online through the link in the bottom right-hand corner. You can follow this link through and look at how different Western European countries have responded to the pandemic. We aim for this to be continually updated. So now I'll hand over to Ruth, who's going to go through an example of how the planner works in more detail.
Great, thank you very much, Josh. So let me just share my screen so you can all see the planner. Okay, so hopefully everyone can now see the GIDA Pandemic Hospital Planner. And yeah, we hope that some of you have downloaded this so that you can work alongside us. So it's made up of 5 sheets. So I think what we'll do is we'll just go through these as an overview, and then we can go back and do an example to see exactly how it is that you can use this to model these interventions. So we begin with the README sheet, which just gives an introduction to the planner. And so all of the information provided here is expanded upon in the user guide, which we would really hope that everyone using the planner would read before performing any analysis here. So also on this sheet, we have the intervention input matrix. So we can see the interventions down this side here that Josh has just spoken about, broken down into those categories. And then we look at sort of what are the elements here that we have modelled in order to get estimates of capacity under each of these interventions. So for the managing admissions interventions, we've looked at these changes in terms of percentage increases in capacity. However, we do appreciate that very often this information does not come in a percentage increase. And so we also provide the option, just further along here, to be able to input these as a figure instead. So this would be something like the number of beds being given in the private sector, that's often reported as a figure. So the idea here is that for each intervention, you can then look across the intervention matrix and see what information it is that you would need to be able to model this scenario. So then looking at the input sheets, so you'll notice that we have 2 of these. So it's very important to note it doesn't matter which one you use because you will end up with the same result. So we have input quick is a simplified version of the inputs so that you can get going with the planner very quickly. So we've identified the baseline inputs which we think are the most critical to the analysis, so things that you really can't proceed without knowing. So this is things like, the number of beds that you have across both categories and staff availability. We also then have the additional COVID related input variables. So we have the non-COVID sort of in E and then the COVID in H here, which I've pre-populated with the values that are presented in the planner when you download. So if we then go further down and we see that again, we have sort of information relating to the different interventions. So I have these down the left-hand side, and then this just translates what we've seen before in the intervention matrix sort of into an easier way to input. So if you can put values in these boxes, you can get started with modelling the interventions. So we can then proceed to have a look at the input extended sheet. So as the name suggests, this just sort of expands upon those things that we've put in input quick. So for example, in terms of the baseline inputs, we also have things in addition to before. So sort of the percentage of COVID and non-COVID patients in critical care requiring ventilation, and also the different safe staffing ratios here that Josh just spoke about. So the idea that these are included in input extended rather than input quick is that we think that these would be fairly uniform across different settings. So we would hope that people wouldn't have to worry about those if you wanted to do sort of a quick analysis, but it is of course important to be aware of these figures and to check that you do agree with them. So I can then go further down. So this is where sort of the intervention inputs come. So this should look hopefully fairly similar to the intervention scenario matrix from before. So basically orange indicates where we have done the values that we've input straight away. And then yellow indicates any calculations that have been done. So for the managing admissions interventions, we put this in directly as a percentage. So these are orange. Whereas here with the use of private hospital resources, which I'm highlighting, as I said before, we input this value sort of as the number of beds and then calculate this based on the distribution across the different categories. So we hope that this is set up in a way that makes it sort of very adaptable for you to sort of alter these interventions if you would like to model them in a different way, and of course to be able to add your own. So then we can start to look at the output of the planner. So again, we have two sheets with the same information just presented a little bit differently. So we firstly look at the numeric outputs. So once again, I have all my interventions down the left-hand side, split into the different categories. So the first thing that I have here is the spare capacity per 10,000 population. This is just saying, okay, so based on all of the patients that I have, and sort of under the assumptions of the staffing ratios and the number of people requiring a ventilator, what can I provide for them per 10,000 population? So green indicates sufficient capacity, whereas red indicates that this isn't sufficient to meet needs under the assumptions that we have included. If I then look further along, we've then calculated the percentage change in spare capacity compared to the baseline. So this is pretty useful to see that, particularly in interventions where, okay, so you're still in a deficit, although you've increased that variable, but actually you can see, okay, this has still managed to have some sort of effect here. So finally, we have our staff planner. So this is based on sort of the needs for all of the beds in the intervention as opposed to all of the patients. So for example, this is just a great way to sort of think about interactions between our capacity variables. So, you know, you can't necessarily just increase beds without having to find some staff to look after the patients who would potentially be in those as well. So we have a similar colour code system here. So once we've accounted for the additional COVID-related sickness, green highlights that you're able to implement this scenario for that particular staff type, whereas red indicates that you would need to find some further resources for this. So finally, we have our graphical output sheet. So we just plot the spare capacity firstly by variable, and so terms of beds, staff and ventilators, and then scroll further down and we can see the output plotted by intervention as well. Okay, so hopefully you're now feeling a bit more familiar with the planner, so I think it's a great time that we can look at doing an example. So for today, I think we're going to have a look at the setting up field hospital example. Okay, so what exactly would I need to do to be able to do this? So I'm going to go back to the README sheet because I'm going to have a look at the intervention input matrix. I find the relevant intervention in here on this left-hand side. I'm just going to highlight it so I can clearly see what I need to model. And the matrix is telling me, okay, I need to know the number of new critical care beds here and also the number of general and acute beds. Then I can go to my input sheet. So as I said earlier, I've pre-populated this according to the values we presented in the planner. Just for your reference, if you click on any of the cells, these values will come up so that you can also see how this works and you can vary it for yourselves. So again, I'm just going to scroll further down and find my field hospital intervention. That's just in row 49 here. So as before, I just need to know the critical care beds, which is 500 for critical care, and 8,000 for general and acute. So then I can look at my output. Okay, so I'm going to have a look at spare capacity. So once again, I want to have a look at the field hospital intervention. So I can highlight this here. So just the one below the dark blue bar. So I can see, even though sort of I've increased the capacity from the baseline here in critical care beds, I still don't quite have enough for the current expected patient numbers to have a look to implement this scenario. I then sort of have a look and I can see that actually on top of this, under the assumption of the one-to-one relationship between critical care beds and nurses, I still also don't have enough staff to fully implement this intervention. However, if I look at the percentage change, I can still see actually, okay, I've managed to increase things by 64% on top of the baseline, although I'm not quite there yet. And this is also further reflected in the staff planner. And so basically this here is just telling me that in 5 out of the 6 categories, I'm able to fully implement this intervention safely. But as seen before, there is a deficit in critical care nurses under these assumptions. Finally, I can go to the graphical output. I think if I have a look for my scenario first, you can see the spare capacity here. So again, this just sort of nicely illustrates the deficit in critical care compared with those of general and acute. So then what I can maybe think is, okay, so I know that there's these issues in critical care beds, so why don't I have a look at this capacity variable, and I can see actually there's a couple of options here where this sort of goes from being in deficit to having sufficient capacity. So maybe I'd want to further explore the implementation of this. So yeah, hopefully this has been a nice introduction to the GIDA pandemic planner. And yeah, I'm going to hand you back over to Josh. Thank you very much.
Thanks, Ruth. So yes, thanks again, Ruth. I'll just outline some of the limitations of this work, and then we can move on to the question and answer session. So firstly, this tool only offers a snapshot of capacity, so it's harder to use for longer term planning for capacity. This is something we're looking to address by integrating these capacity modelling scenarios into work done by the FE team to assess how changing numbers of cases through time affects capacity. And secondly, the implication of these interventions in terms of reductions in quality of care are not fully elucidated. For instance, without intervention of cancelling elective surgeries, we do not model how this would affect these patients' outcomes, simply the capacity gained from this intervention. Within the COVID team here at Imperial, this problem is trying to be addressed in a separate workstream, although it is quite hard to elucidate here in this planning tool. And finally, we're also trying to make our assumptions as clear as possible in the report and user guide, but users still must understand these when taking results from the model. So thanks for listening, and now I think we'll hand back over to Oliver to moderate the question and answer session.
Well, thank you very, very much, Josh and Ruth, for those excellent presentations. That was very interesting. So as Josh said, we're going to move on to questions and answers. Through the registration process to this webinar, you had an opportunity to kind of submit a question. And we have had many, many excellent questions coming in from you guys. So we're going to do our best to answer at least a kind of representative selection of them. So I'm going to start with the first question for us for today, which is for Nora. So can you tell us if the planner can be modified for use in lower and middle income countries?
Yeah, so as you have just seen in the presentation, the planner was developed with Western European countries in mind, and that affects both the key resources we chose to include, for example, the ventilators, and then secondly, also the interventions that have been considered by these countries. And some of these interventions might well be applicable in different settings. And for those, the user can change the percentage changes in capacity like Ruth has shown in the demonstration. But then other interventions would not be feasible maybe to be implemented in low and middle income countries. So what I would recommend is that the user first assesses the existing capacity and then sees what would be realistic of these interventions in their setting. And they can also, for example, add their own interventions in a new row in the planner. I'm not sure, did anyone else maybe want to add something?
No further comments then? Very good, thank you very much for that, Nora. The next question is for Alessandra. So can an indicator be developed on the basis of the planner to measure pandemic preparedness in different countries?
That's a great question. So it really depends on what you're looking for the indicator. What our planner can do right now is that we can see the number of COVID patients that will lead you to have spare capacity or whether you will go overboard. So in terms of pandemic preparedness via capacity, then you will be able to know from that. But in terms of number of infections, probably not, because we are only looking at hospitalized patients.
Thank you very much.
Anyone has anything else to add to that?
No, you did a great job, Alessandra.
It's very comprehensive. Excellent. Let's move on to the next question then. Oh, we're going through these quickly. You might be able to answer most of the questions that we've selected. All right, so this one is for Ruth. Can you explain some of the specifics around model assumptions and how these might affect the results?
Yeah, absolutely. I think this is a really important point, and I think it's very critical to be able to use the planner to understand this. So as I alluded to when I was going through some of the examples in the planner, you know, for things like private hospital care use, you get sort of a figure of, okay, there's 8,000 beds, but obviously the planner requires that you need to be able to split this down into critical care and general and acute. So for example, with this, we've said, okay, so at the baseline in the NHS, we see that around 4% of all beds fall into critical care. So sort of in the absence of any other information, we feel that this is an acceptable proxy to use in allocating up those beds. So of course the assumption here is we might have actually sort of under-captured critical care if it happened to be that private hospitals had more of these resources. So it's just like things like that are really important to think about sort of when you are using the planner, and it will have an effect on spare capacity.
Thank you very much, Ruth. Does anybody else want to add to that? I'll take that silence as a no. Okay, so the next question that we have is for Paula. So is this tool aimed at experienced health workers, or can it be used by anybody?
Thank you very much for the question. Essentially, the tool can be used by anyone, really, but it is mainly designed to support decision makers specifically and hospital administrators. So nonetheless, its versatility allows the users to adapt the tool to healthcare systems of different scales and scopes, and can be tailored to healthcare systems characteristics in the extended input sheet that was presented in the practical part of this session. Thank you.
Great, that's very useful to know. So I think we'll move on to the next question. Thank you very, very much. So this one is for Dia. Does the GIDA pandemic hospital planner model the adverse effects of interventions? For example, increased morbidity from the cancellation of elective surgeries. And also, how long will the hospital care system be able to apply those measures without greatly affecting other healthcare services?
That's a really good question. Very interesting, and I think it's a very important area to consider. However, the GIDA planner, it's out of scope to answer or address these kind of considerations. Estimating and modeling adverse effects and any consequential effects on other areas of health and health services is rather complicated and requires an understanding and estimating the shadow price and opportunity cost of each intervention across all areas of service. It's actually an ongoing project for the Imperial team and is proving to be a little tricky to fully capture all possible scenarios that will come out of implementing each intervention and the probabilities of them occurring. So I'd actually say just keep an eye out for an upcoming report that hopefully will try and address this.
All right, thank you very much for that. Right, very good. Let's move on to the next question. This one is for Josh. So how can you use the GIDA pandemic hospital planner to look at primary and secondary care hospitals? And also, how could this be used in community hospitals or healthcare centers?
Thanks, Oliver. That's a really good question. So the planner initially was built to be used sort of at a regional or national level. So hopefully this would take into account both secondary, primary and tertiary care. And it's built to be quite flexible across different healthcare settings. So with secondary care, if you wanted to model this based on assumptions of critical care and GNA, then this would be fine, but you might miss some of the granularity of other treatments here from different clinics being run. And in terms of primary care, this would likely require a different tool, as we've based the plan on looking at beds and ventilators, which is not sort of the level of care that you receive at a primary care level. And hopefully local decision makers, though, can use it to decide staff rotations and allocations for COVID during this pandemic.
Thank you, Josh. I have another question for you before you switch your video off. So does the GIDA pandemic hospital planner include a triage system? How this works?
That is another great question. So sort of, so one of the interventions we look at is the NICE guidelines, which is sort of how to allocate critical care, which affects sort of triaging of critical care. And this, at the moment, this sort of analysis for the effect of this is done very specifically for England. So if this was to be used in a different setting, the rationale for triaging appropriate to that setting would have to be analysed, and then looking at how that would affect patient populations for input as the baseline. So that would be something for the user to input. So the tool is quite flexible in that that's something they can do.
Great. Well, thanks very, very much, Josh. We'll move on to another question. I realize that all of these questions are coming from our learners all over the world, and I haven't been specifying. So I'm going to start doing it from now, just so you get a bit of an idea of how diverse our audience is. So this question is coming from a student in Lithuania, and it is for Paula. Did you turn your video on, Paula? Yes, I might just stop yours, Josh. All right. How do countries manage extreme surges? How would you evaluate planning and execution for these countries?
Thank you for the question. It's very interesting. So we have tried to cover as many countries in our analysis as possible and have summarized the surge capacity interventions in the report by focusing on 11 West European countries that we looked at in more detail. And the interventions included a variety from setting up field hospitals to employing students in their final year of studies, as well as cancelling elective operations. Nonetheless, we reserve judgment on what countries have actually put into place. Though through the tour, we hope to support decision makers in planning efforts. So in case you would like to have a further look at what countries have done, we would advise you to look at the Health Systems Response Monitor for further details, which are country specific. Thank you.
Very good, thank you very much. Let's see. Question, I suspect that question 11 is also for you, Paula. So where did you get your data for the hospital planner? It's a question from a student in the United States.
Okay, sure. So the data was mainly gathered from, So the data was mainly gathered from publicly available sources from the English National Health Service. So we would advise the user to do the same for the specific country. And it is strongly advised to seek the opinion of clinicians and medical experts in order to make sure that the data gathered is realistic and reflecting reality, essentially. Also, we would advise you to consult the literature and national guidelines for the country in order to understand what the required number of staff per bed capacity and ventilator capacity are. And most of the examples that we've made so far are based on an England example.
That's great. Thank you very much, Paul. So the next question that we have is for Nora. And it's coming from a learner in the Philippines. So would it be possible, or rather feasible, to develop a similar tool which would look at the changes in healthcare patterns or needs amongst non-COVID-19 patients?
Yeah, that's an interesting point, the non-COVID patients. So the planner does distinguish between those patients who are in hospital with COVID and those who are in hospital at the same time with other conditions. Of course, our current focus is how hospital capacity can be adapted to prepare for the surge in COVID patients specifically. But you could certainly adapt it to also reflect the changes in the healthcare use that have, for example, been reported more generally during the pandemic. However, if you wanted to add any further intervention, you would certainly need to view it in the light of what the critical resources are for these non-COVID patients, and that will definitely depend on what conditions they actually have.
That's very interesting. I have another question for you, Nora, this time from somebody in the United States. Can you tell us whether the GIDA pandemic hospital planner can be used with other disease models such as HIV or malaria?
Yeah, so that relates to the previous question, in the sense that these patients would, in some settings, fall in this category of non-COVID patients that do always present to. You have to keep in mind that the resources that are required to treat patients with HIV and malaria, for example, are very different for the those that are required to treat COVID patients, because they're not respiratory conditions, for example. So although you could not explicitly relate the two, the overall structure and approach we have employed in developing this planner could certainly be used for other diseases. But you also need to ask yourself, what is the primary use of the tool? And here we look specifically at a surge of patients that would come with a break. So maybe not with endemic conditions as much.
Good, thank you very much. So the next question that we have is for Dia, and it's from a learner in the United States. How can the planner be used with electronic health records?
Definitely can be used with individual medical records, so which is the class that electronic health records would be. You would need to aggregate the records to obtain the total number of individuals by COVID and non-COVID on a certain day or whatever time period you plan on using the planner for. And these two numbers will feed in as inputs to the model.
Great.
Yeah.
Very concise, thank you. Great, so moving on to the next question. This one is for Ruth. Can you tell us how frequently does the tool update with current information?
Yeah, of course. So I think we can kind of break this question down into two categories. So if we firstly think about the interventions, so we are always looking at the European Observatory Health System Response Monitor to see the information that is coming out there in terms of any new interventions being implemented. But I would say sort of in that light, we really tried hard to set up the planner so that it can be easily adapted by anyone who uses it. So we would hope that the way it is now, that you can add in your own intervention or a combination of interventions that you want to look at, But of course, we would be delighted if anyone got in touch and they wanted to discuss any sort of specific points a little bit further on that. So then the second point of this, sort of looking at the baseline variables. So the information that's put in there just now is very much sort of an illustration of how the planner can be used, rather than necessarily being the most accurate reflection of any health system. And so we won't be updating these. Thank you.
Thank you very much, Ruth. So we're going to move on to the last question from the pre-submitted questions. And this one is for Josh. So how is the GIDA pandemic hospital planner being used and tested in the real world? And this question is coming directly from the UK.
Thanks, Oliver. Yeah, that's a good question. So we've had inquiries about the tool from numerous governments, and also in discussions with the WHO about incorporating this with their tools for capacity management, and it's been featured as a key resource on the WHO and European Observatory websites. And we're not sort of at liberty at the moment to speak about specific user cases, but we do also always love hearing about how the tool has been used. So if you are thinking of using this going forward, we'd love to hear back from you, and we can also answer any more detailed questions you have as well. Thanks.
Thanks, Josh. So now we're going to move on to try and answer some of the questions that you've asked during the webinar. There is a really great selection of questions. I'm going to start with a question for Alessandra. So does the planner also allow for changes in discharge rules for non-COVID treatments? And also, do any of these assumptions reflect CC bed capacity based on the time of stay of COVID-19 patients? Oh, you're muted. Sorry, yeah.
Sorry, technical difficulties. So as it stands right now, the planner is not dynamic, so you have to put in your own number of COVID and non-COVID patients. And we're really looking at a prevalence of patients in the hospital, and not the admissions or the patient journey or the length of stay or discharge. We are potentially going to be moving forward and expanding this, but currently, right now, we've just had the planner be static so that people can get an idea of what interventions they should look at to begin with.
Great, thanks. We have another question for you. So is there a list of critical assumptions, including parameters, values, etc., of the planner tool?
Yes, you can find all of that in our report, which you should have the link to because it's the same link as where you downloaded the planner. And that has a table with all the values and our sources, and also the assumptions that we made in our interventions. Please read this. It's very important that you read the assumptions for each models, for each intervention before you use the planner, because we can't assume that the England example will apply to everyone, as I think Nora previously said about lower middle income countries. So it's very important that people read the assumptions if they can before using the planner.
Yeah, that's a really good point. And I think also true in general for any kind of modeling studies.
Yeah.
Really, really important. So thank you very much for answering that. And also thank you very much for asking that question. The next question that I have is for Ruth. Is the GIDA planner, can we use it in large population countries? Or is it just for kind of medium population countries?
So again, I think this is an interesting question, and it relates back to the flexibility and adaptability of the planner. So the way that we've built it is we hope that actually it's fairly independent of size, in that it can be used sort of in the UK at a trust level, going up to regional, up to national. So the only thing that you would really need to change there is just the reference population input. That sort of goes into the calculation of the spare capacity per 10,000 people. But yeah, absolutely, it can be used in many settings of many different sizes.
Great. very interesting. Thanks very much. We're now going to move on to another question from the audience. So COVID-19 doesn't mean other medical emergencies have reduced. Certain elective surgeries may also be required immediately to prevent, say, paralysis. How can we adjust the existing medical emergency with the baseline medical needs? And I put this to the entire panel. So whoever wants to take this question, just come forth.
I can take it.
Thank you.
So actually what we assume throughout is that emergencies, that there is still healthcare provision for emergencies throughout. The only thing we modify is elective surgeries, so that you, as many countries have considered, pausing those to deal with the incoming COVID patients. However, that raises just a very good general point that now many governments are thinking about how can we reintroduce even these electives, as the existing medical need has not disappeared, as you bring up.
Thanks very much, Nora. Does anybody want to add on that? This is the moment to do it. If not, we...
Yeah, just sorry.
Oh,
yeah, just to add to Nora's point, yeah, this is something we are looking at further with the planner, and looking at how we can use epidemiological forecasts of patient numbers to work out when is the best time to reintroduce this elective care. It is a very pertinent question, and it's something that definitely needs to be analysed before, if we don't want like a large backlog of these elective patients, which then become more acute as their treatment is delayed.
Thanks, Josh. So we have a question now from Christina Lawrence. Is there any way to see which variables, for example, increasing the numbers of ventilators or staff, would be the most effective in moving kind of red deficits into the green without having to just do trial and error? So this is a kind of a question about the technical use of the planner.
I can answer that one. So we're hoping to develop a dashboard shortly. Can everyone hear me? Am I still on mute?
No, we can hear you loud and clear.
Yes, so we're hoping to develop a dashboard shortly, which, as Josh said, is going to be integrated with the EPI forecasts. So that will be much more interactive. Initially, our plan was to keep it as an Excel sheet that was you can just download it, and it would be easier in case you're in somewhere that doesn't have internet connection, for example.
Great, thank you very much. If there's anybody else who would want to add on that?
Yeah, I think it's a great question. I think a couple of the interventions that we model, so upskilling general and acute staff to critical care staff, and converting GNA beds and theatres to critical care beds are really flexible, I think, at a national level. So we can, part of the next series of work is looking at how sensitive capacity is to changes in the rate of these alterations to current bed stock and staffing numbers, to see how this can affect capacity. So it's more adaptable, as the question states.
Great, thanks. So I'm going to move on to Juan Carlos's question. Do you think the GIDA pandemic hospital planner would have had a different impact in the early stage of the epidemic?
I can answer that question. So essentially, whether the planner could be useful or not depends really on the amount of capacity that can be freed up. So it is very country specific. And then of course, it also depends on at what point a country starts to plan their capacities and reconsiders whether capacity needs to be freed up. So whether it would have had a greater impact at an earlier stage, we wouldn't know that. And we wouldn't want to make any judgment about this. Yet in the future, it should be considered to support any decision makers. Thank you.
Great, thanks. I think we have time for maybe one or two more questions before we start having to wrap up. So I'm going to take a question from Marshall Feldman. When you talk about patient input, Are you just using projections of peak admissions?
So we are actually not making or using any projections at all. With the planner, we are only given an example of England data, and this is data of COVID patients that were in critical care a while ago now at the beginning of April.
Great, thanks very much, Nora. I think we have one last question to take from me here. Can the GIDA hospital planner overcome the crisis of less number of health resources because the COVID-19 pandemic is spreading like fire? Okay, so this is more of a question about the usefulness of the hospital planner in the context of the stage of the pandemic. I think it's similar to the question about impact that we had before. Does anybody want to comment on that again?
I'm happy to just briefly say that I think the tool really can be used in order to help decision makers sort of face these difficult choices by quantifying things in terms of capacity. So we really do believe it's one critical part of the response, but it's just one of several things that go into sort of to helping to deal with the pandemic.
Thank you very much, Ruth, and thanks to all of our wonderful members of the panel and all of the people who supported coordinating this webinar. And most of all, thank you, our participants, for coming and engaging and asking such interesting questions. It is always useful for us to, I guess, think. It helps us think about the science that we do. So thanks very much. We're going to wrap up now. And you will be able to access the live recording. We'll be in touch about that. Thanks, everybody. Maybe everybody can put their videos on and wave goodbye to our learners. Bye, everyone. Thanks.